Welcome, everyone. Today we have three speakers, Ainsley, Christina, and Emily. You're all very familiar with them. And the topic is on the screen for you now. This is implementing exercise as a treatment modality for psychiatric disorders. Introducing the speakers, you all know all three of them, but I'll just read out their bio briefly. Ainsley Alexander, he did his medical school and residency at Queen's. And after that, he did child and adolescent psychiatry at the University of Ottawa. And he came back here. He's pleased to return to KHSC, in addition to enjoying running and reading, probably both not together. He's also a long-suffering fan of various Toronto sports teams. Christina, you know her, Christina Moy. Dr. Moy is an adult psychiatrist with her outpatient practice consisting of general, adult, and bariatric psychiatry. Also a member of the substance treatment and rehab team at KGH. Exercise is Christina's preferred way to relieve stress, and she hopes that one day she may be lucky enough to have an office with a shower attached, so she may be able to break up her clinical day with a lunchtime run. So that's an idea for our future. For now, she is happy to settle for speaking about exercise during this lunch hour. And Emily will be joining us shortly. She's just running a little bit late. She's my immediate colleague, geriatric psychiatrist in the division of Geri Psych at Queen's. She did her MSc in community health and epidemiology at the Queen's. And after that, she worked for Canadian Institute of Health Information. She then completed her general psychiatry and geriatric psychiatry residency training at the Queen's, and then became a fellow of the Royal College with of Physicians and Surgeons of Canada in 2020. She currently works on the inpatient BPST unit at Providence Care, works with the seniors mental health outreach team in Hastings and Prince Edwards, and sees older adults in the mood disorders, and is undergoing certification for IPT and co-leads a CBT group for older adults twice a year with a neuropsychologist. Thank you, Emily, for joining us. Thank you all. And I hand over to our esteemed speakers.
Good afternoon, everyone. Thank you so much for joining us today for Grand Rounds. My name is Dr. Ainsley Alexander. To my left, I have Dr. Moy, and to my right, joining us right on time is Dr. St. Denis. So we'll get started in terms of our talk. We'll kind of break this up between the three of us speaking, and we'll take questions at the end. Of course, if you have questions at any time, we're happy to address them at that time. So as you can see from the title slide, our discussion today is going to be on implementing exercise as a treatment modality for psychiatric disorders across the lifespan. And to begin, let us acknowledge that Queens is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We'd like to disclose our conflicts of interest and disclosures. Dr. Moy and Dr. St. Denis have none. I have moderated for Otsuka Pharmaceuticals in the past. In terms of our learning objectives, we'd like to review the evidence for exercise in the treatment of psychiatric conditions, review different barriers and strategies for implementing exercise as a treatment modality in the various age groups. And we'd also like to participate in discussion regarding real-life experiences through case examples. So let's start off by talking a little bit about exercise stats and how Canada is doing. And the Coles Notes version of it is that we're not doing especially well. So the large majority of Canadians are not meeting the recommended physical activity targets. And you'll see those individuals between 12 to 17 years of age, 69% of them are not meeting the physical activity targets. So that means around less than a third of the people in that age population are not meeting those targets, or are only meeting those targets. In the adult and older age population, 83% of people are not meeting these targets, which means roughly 1 in 6 Canadians. And that's especially a troubling number when you compare that to the worldwide numbers. And we are about 4 times as many adults in Canada are not meeting their targets compared to individuals in their worldwide cohort. In high-income countries, 26% of men and 35% of women are insufficiently physically active, as compared to 12% of men and 24% of women in low-income countries. And then I really like the slide, courtesy of Dr. Moy, as to why is physical activity a problem. This cycle demonstrators that sedentary lifestyles increase all causes of mortality, doubles the risk of cardiovascular diseases, diabetes, and obesity, and increases the risks of colon cancer, high blood pressure, osteoporosis, and lipid disorders. This in turn leads to chronic diseases, for which we know there's a bidirectional relationship with depression. When thinking of depression and anxiety that result, the rates of co-occurrence of depression and other chronic illnesses are displayed here on the slide. According to the World Health Organization, 60 to 85% of people in the world from both developed and developing countries lead sedentary lifestyles, making it one of the more serious yet insufficiently addressed public health problems of our time. Then we talk a little bit about why exercise is beneficial. On the flip side, when we look at the benefits of exercise, there are definite physical health benefits, basically reversing the issues that arise because of physical inactivity, as well as psychological benefits. Highlighted there or here are the benefits very relevant to our field, including improved quality of sleep, reduced feelings of anxiety, improved quality of life, reduced feelings of depression, and reduced incidence of depression. Given that inactivity is a modifiable risk factor, it is something that is important to think about and address. Let's talk a little bit about evidence for exercise in the treatment of psychiatric conditions, and we're going to break this up between the child and adolescent population, then we'll transition to the adult population, then the geriatric population. So I want to begin by thanking everyone, and I should have done this right at the start, for taking time out of their busy schedule to participate in Grand Rounds today. We certainly hope that this is edifying for you as it has been for us in terms of learning about the benefits of and barriers to implementing exercise as part of our patients' treatment plans. The picture you see here is of me. At that time, a young kid whose dreams of being the next soccer superstar were squashed by my mediocre athletic abilities. But in my metamorphosis from aspiring footballer to pickleballing physician, I have learned the benefit of being physically active. Speaking of exercise, please be on the lookout for a potential staff resident soccer game that will be hopefully organized for June of 2024. Okay, so let's start off by talking about exercise in the child and youth population. Poor physical health of people with mental illness has long been a source of concern. Indeed, this has been labeled an international human rights scandal. Organizations like the World Health Organization, the World Psychiatric Association, and the Lancet Psychiatry Commission have all developed guidance regarding ways to address poor physical health. In addition to being of benefit to one's physical health, exercise can also reduce the risk of developing various mental health conditions, while also acting as an effective adjunct intervention for reducing symptoms in those living with mental illness. So not only can exercise be prophylaxis against mental health conditions, but it can also be an important treatment if such conditions are already established. Unfortunately for our patients, children and young people with mental health conditions can exhibit signs of poor physical health from the early stages of diagnosis and treatment of mental illness, and these signs can likely even be seen in the prodromal stages. Physical health challenges such as obesity and metabolic diseases, for example, can be observed in children and youth who have been diagnosed with a psychiatric disorder. And we talk a little bit about the benefits of exercise for children and young people. Engaging in physical activity has many benefits for children and young people, including helping to improve self-esteem. Young people who have higher levels of physical activity also have higher. So we're going to finish my section off by talking about the benefits of exercise for children and young people. So engaging in physical activity has many benefits for children and young people, including helping to improve self-esteem. Young people who have higher levels of physical activity have also have higher levels of well-being, improved quality of life, increased life satisfaction, and are less likely to be diagnosed with a mental health condition. As well as improving symptoms of poor mental health during adolescence, there's also evidence that indicates that exercise provides protective effect and may reduce the incidence of mental illnesses such as depression and psychosis in the future. As noted by the World Health Organization, the benefits of exercise for children and young people are far-reaching. Some of the notable physical health benefits include improved physical fitness, improved cardiometabolic health, for example, blood pressure, better bone health, ability to maintain a healthy weight, improved sleep, and higher cognitive functioning, as evidenced by improved academic performance, executive functioning, and brain health. Partaking in regular exercise during childhood and adolescence also has significant benefits, as well as significant social benefits, as well as improving self-perception, quality of life, confidence and ability, and self-efficacy. I'll transition over to Dr. Moy.
Great. So I'll be presenting the evidence for exercise in the adult population. And this is a very big topic, so I'm trying my best to try to just make it very concise. And I think a lot of this will also overlap with the evidence that Dr. Sandini will present, as they often include older adults in these studies. So just starting with depression, we know that the CANMAT guidelines, again, that guidelines do consider exercise as a level 1 monotherapy for mild to moderate MDD, as well as an adjunctive treatment that's second line with level 1 evidence for moderate to severe MDD, which is all to say, no matter what the severity of depression that we're seeing in our population, we should likely be considering exercise in some way. I just wanted to point out some of the landmark studies in supporting these guidelines, one of them being the SMILE study, which stands for Standard Medical Intervention versus Long-Term Exercise Study. Here they had a group of about 156 men and women, and there were 3 main groups. So there was an exercise-only group where they participated in supervised exercise sessions 3 times a week for 16 consecutive weeks. Each aerobic session started with 10-minute warm-up period, followed by 30 minutes of continuous aerobic exercise, and then concluded with 5 minutes of a cool down. There was a medication-only group. So they were followed by psychiatrists, started at 50 milligrams of sertraline, titrated up to 200 milligrams as needed, and seen at weeks 2, 4, 8, 12, and 16, and then a combination group of exercise plus sertraline. The end result that there was no statistical difference between these groups, indicating that exercise itself was just as effective as medication and combination therapy. What they didn't necessarily look at here, though, were the physical health benefits that would have also come from increased physical activity. So looking at this for myself, if we're able to get patients to engage in exercise, we're not only addressing their depressive symptoms, but also the physical health benefits that we discussed earlier. I'll say there are a lot of different studies that they did off of this primary study, where they looked at, for example, supervised exercise sessions versus home exercise, and they actually found compliance better with the home exercise. So I think oftentimes, I initially looked at this study thinking, maybe the supervision 3 times a week is maybe what was beneficial. But I think there is evidence based on some of the studies that they did afterwards that it's more than that. So their conclusion was that an exercise training program can be considered an alternative to antidepressants for the treatment of depression itself. They also did a follow-up study at 10 months to look at whether or not exercise was maintained after the supervised exercise group ended, as well as looking at the depression remission rates. And so overall, their conclusion was that at the end, the remitted subjects in the exercise group actually had significantly lower relapse rates than the subjects in the medication group or even the combined group. And that combined result is a little bit confusing, just because you'd think it would have the combined effect of both exercise and medication. But they do speak to this a little bit in their article itself, and they're proposing that maybe, one of the big benefits of exercise can be that positive psychological benefit, where you're really getting personal mastery and you're feeling really good about yourself because you're thinking, hey, I put in all this effort and that's how I improved my own outcome in terms of my mental health. Whereas maybe if that medication is added on, that some of that psychological benefit may be taken away. Just wanted to note here, there are a lot of additional meta-analyses, systematic reviews that have come out more recently since from 2023. And so there is a lot of additional evidence just to support the fact that in depression specifically, exercise is very beneficial. So in this most recent one, a number needed to treat of 2 was found for a clinically meaningful reduction of depressive symptoms from moderate to mild depression. And that was significantly less than what they found in this particular study, which was a psychotherapy number needed to treat of 2.5 and a medication number needed to treat of 4.3. In terms of anxiety, there's a little bit less evidence in terms of clarity compared to depression, but there is definitely still benefit that has been seen. So for panic disorders, acute aerobic exercise can reduce anxiety as well as panic attack frequency and intensity in patients with panic disorder. There's also some evidence for OCD, where adjunctive moderate intensity aerobic exercise is recommended, and it can reduce the symptom burden within OCD. And there's also some evidence that exercise can reduce the risk of developing an anxiety disorder and can reduce anxiety symptoms overall. Again, there are tons of more recent studies that support its benefit in terms of reducing anxiety symptoms, particularly among sedentary patients who have chronic illnesses, which may not be a surprise. That study specifically on trait anxiety and promoting working memory and inhibitory function, as well as lower social anxiety symptoms in those who are physically active. So I think still pretty good evidence overall, but maybe a little bit more difficult to study compared to the depression population. Then particularly in ADHD, we know that establishing structure and routine is really important. So that's where exercise can play a big role with ADHD. So when we look at physical activity guidelines that we'll see later on, oftentimes they'll say a certain number of minutes per week. With ADHD specifically, it can actually be helpful to do it, daily or more days in a week than not, just to build upon that routine. That's important. So while there isn't evidence that exercise can replace stimulants or ADHD meds, it can be helpful as an adjunctive treatment. And there is some evidence that for patients who exercise daily, they may actually need a lower dose of stimulants themselves. So for example, if somebody is exercising immediately in the morning where they need that concentration boost, maybe that's when they do their work, then they have usually like a good hour of increased concentration and attention, and maybe they can take their stimulant an hour later. On the flip side, if somebody's stimulant is really wearing off very early, it could be that in that wearing off phase, you can implement some exercise, and rather than giving a top-up of a stimulant, perhaps you may be able to get away with less of a stimulant load. In terms of bipolar guidelines, we know psychoeducation is key, and one of the things that they note is that getting regular exercise is definitely recommended. There is a little bit of a double-edged sword here, just to know about in terms of bipolar disorder. A little bit more research is needed. We know that the pros can be that there are less depressive symptoms, a lower BMI, has a higher quality of life and functioning, and maybe in patients who have excess energy, it can help to redirect that energy, and maybe be a little bit calming, for example, for patients in hypomania. It can increase sleep quality. However, on the flip side, it can be seen that maybe more exercise is associated with experiencing more mania and more manic symptoms. So, I think it's hard to tease out, is it exercise that's causing mania, or is it the mania and the excess energy that's resulting in people exercising more? In terms of schizophrenia and other psychotic disorders, it's not specifically mentioned in the Canadian guidelines in terms of recommending exercise, but it is recommended in Australian and New Zealand guidelines that, at least metabolic monitoring and advice about diet and exercise are something that's essential, and I think something that we tend to talk about in terms of the monitoring anyways. In studies, they found that exercise can definitely help to prevent weight gain in patients with schizophrenia, can reduce abdominal obesity. That's essential for preventing type 2 diabetes and cardiovascular disease. So we know that's linked to early death in this population. And it can also help to reduce the weight-related social stigma, improve overall quality of life, and also treatment adherence, which is key in this population as well. There's some research so far that can also benefit negative and positive symptoms, but definitely more research is needed in that way. So this is an overall summary. Really, there's fairly good evidence to think about exercise in most of our main psychiatric disorders. So I'll hand it over to Dr. St. Denis for exercise.
Hi. Yeah, sure. So hi everyone. So as Dr. Moy was saying, a lot of the evidence is sort of similar to the general adult population, but I'll highlight and focus on a couple of key differences and some things that are unique to the older adult population. So there are physical guidelines put out by the there's Canadian Physical Activity Guidelines and Sedentary Behavior Guidelines, and typically they recommend at least 150 minutes per week. Or 90 minutes of moderate intensity exercise. That said, though, there was a prospective cohort study done in Taiwan that showed that even 15 minutes a day could provide benefit for reducing mortality and increasing life expectancy, even in those with at risk of cardiovascular disease. So it might not even need to be that much per day, but at least this is sort of the recommended guideline. So a lot of the recommendations in older adults is in terms of prevention. So this graph is from the 2020 Lancet Commission on Dementia Prevention, and in it they talk about meta-analyses and longitudinal observational studies that have consistently shown that exercise is associated with a reduced risk of dementia. You can see from the graph around later life, if physical inactivity was eliminated, there would be about a 2% reduction in dementia prevalence. So older adults who have mild cognitive impairment or subjective cognitive decline are recommended to participate in that kind of, minimum guideline of moderate intensity physical activity for at least 150 minutes per week. As Dr. Moy was saying, so the evidence for anxiety is not as good as some of the other conditions. But these are from our CCSMH guidelines that do still recommend, considering exercise for older adults with anxiety symptoms. They felt, so even though the evidence wasn't that great, and there was only one study included in this that was with older adults with anxiety disorders, they still felt that this was a conditional recommendation to be made based on other higher quality evidence for older adults in terms of like reduction of falls, osteoporosis, cardiovascular disease, and depression. What there is more evidence for is its use in the fear of falling. So again, this recommendation about exercise, including Tai Chi and yoga, is from the CCSMH guidelines. And there have been several systematic reviews that have confirmed that exercise interventions are effective in reducing the fear of falling in older adults. So the other thing to consider too is that some exercise programs not only reduce this fear, but also lead to objective improvements in balance and a reduction in falls rates, which is again important for this population. So similar to the adult recommendations, there is evidence for the prevention of depression, social isolation, and loneliness in older adults. Their higher levels of physical activity are sort of consistently associated with the lower odds of developing future depression, even in older adults. I won't go through all the meta-analyses and things like that, but just to say that there's better evidence for the prevention of depression, but there is also some evidence for reducing depressive symptoms. And primarily those are, exercise and mind-body interventions like Tai Chi, yoga, and mindfulness-based stress reduction. Oh, can you hear me? Okay. Okay. Oh, did I? Yeah, I do not do karaoke. So, so I will talk about behavioral and psychological symptoms of dementia. So our CCSMH guidelines also recommend and suggest physical exercise for the management of agitation in dementia. A systematic review and meta-analyses have shown that physical exercise, mostly aerobic, but also some multi-component exercise interventions, is associated with a reduction in overall neuropsychiatric symptoms. There have been other studies that looked at the effects of agitation, and again, this was aerobic exercise and primarily walking. And they have found that this showed a reduction in symptoms of agitation when compared to usual care. Oops. The other thing to keep in mind too is in depression associated with dementia, there is also some evidence for recommending physical exercise for the treatment of these symptoms as well.
So yeah, now we'll discuss a little bit about cases that we've seen or different situations that we think are applicable to how we can address some of the barriers that are impacting our specific patient populations. So we'll start off with an anonymized case that of a young boy that I saw. And first, let's talk a little bit about factors that impair children and young people diagnosed with a mental health condition from being able to engage in exercise. and thereby put these individuals at higher risk of developing a health condition. So substance use, unhealthy diet, low motivation, lack of energy, social withdrawal, increased anxiety, lack of access to safe outdoor spaces and facilities. So those are some of the barriers, and in the context of Sebastian, the anonymized patient that I'm going to talk about, we'll see how some of those factors come into play. So Sebastian is a 15-year-old boy referred to me by a nurse practitioner for diagnostic clarification and treatment recommendations due to school refusal. The referring clinician wondered if the patient was depressed. Now, Sebastian, who resides in the Greater Kingston area, lives at home with his bio mom and stepdad. He has no contact with his bio dad and has no siblings. He gets along well with everyone at home. In the context of our assessment, what comes out is that Sebastian is being bullied pretty badly about his weight. This is the primary reason he's refusing to attend school. This has resulted in a cascade effect where he has gotten further behind academically, leading to anxiety. And you'll see that ultimately his diagnosis is social anxiety disorder. Moreover, he has missed out on making social connections because he spends most of his time at home playing video games online. His stepdad so when we talk about some of the challenges you might experience from a psychosocial perspective, his stepdad wants him to toughen up and not let what others say bother him. His mom feels badly about the bullying and therefore acquiesces to whatever he demands in order to help him feel happy, because she feels a little bit guilty about what's going on. In addition to the usual treatment strategies we talk about, such as psychotherapy and pharmacotherapy, what is another strategy we could recommend? You guessed it, exercise. I'm bringing this up with the family. They were open to it, but also put forward some reservations that are quite common in my patient population. So stepdad says, we don't have the money for these leagues. And you'll notice from the social history perspective that the parents are unemployed at this time. Mom notes that he doesn't like to be active and she doesn't want to push him beyond his comfort zones at this time. And the patient himself notes that he prefers to play games online as opposed to being in person. While all of these are understandable barriers, they need to be overcome because, as we have identified, exercise is a key part of a person's mental and physical health. Sorry, my mistake. In this situation, we identified activities that did not require a huge expenditure. He can start off by going for walks instead of joining rep hockey, for example. They can also look at companies like Play It Again Sports to get gently used equipment, as these types of stores might be more cost effective. We also collaborated with mom about how accommodating requests can actually not be in the best interest of the individual. For example, we discussed the need to limit unhealthy snacks and screen time, and also about emphasizing the importance of physical activity. We also collaborated with the patient, most of all, about what exercise he might enjoy, soccer, for example. Ultimately, we developed a plan that was satisfactory for all parties, and one where exercise was a key component of establishing a positive trajectory for the patient. And I'll pass it back to Dr. Sainty.
Kind of similar, I think, in a lot of these cases, while there are barriers, one sort of has to think a little bit outside the box. And a lot of the literature in our population, does discuss that a lot of these things can be mitigated. So some things to consider in the older adult population are, physical limitation costs. A lot of our seniors are on fixed income. There's also sometimes an inadequate distribution of information, what's available, and lack of professional guidance. In the community, though, there are free and low cost options. Patients can be referred to groups. I not infrequently refer people to Seniors Day Rehab or physiotherapy if appropriate. Home and community care also has physiotherapy and occupational therapists. There are senior centers, usually community centers have groups. There are mall walking groups. So there are, again, it's sort of a bit of working with the patient and, trying to think a bit outside of the box. So there are also, and I'll talk on the next slide too, there are Canadian resources to help older adults choose higher. Okay, sorry. Okay, can you hear me now? Sorry, guys. So as I was saying, so there are Canadian resources to help older adults choose exercise based on their physical abilities. So there's a program called Active Aging Canada. We talked again about the national guidelines earlier, and on the next slide, I'll talk about the Fountain of Health, which is another great resource for clinicians as well to help with this stuff. The other thing to keep in mind about older adults, especially if you're working in individuals with dementia and behavioral and psychological symptoms, there might be difficulty in accessing resources or motivating others. You usually need to get buy-in from allied health professionals or caregivers. But I have had success with a couple of patients where we'll try like a QB bike in retirement homes, for example, which works nicely until the person sort of loses the ability to coordinate this. But we also have like a walking program on our ward at PCH as well. I've also, to sort of talk about some cases in generalities, I have seen several patients where their decline in mobility and limitation in mobility has caused a significant role transition, and then it leads to both depressive and anxious symptoms. So I have one patient in particular that I, again, referred to seniors day rehab. And I think that physiotherapy has really increased her confidence, her motivation, and reduced a lot of the depression and anxiety symptoms that she came to see me for. So this is, I'll try to click on it just in case it doesn't work. But so the Fountain of Health is a nonprofit initiative developed at Dalhousie in 2011. And it really is designed, it sort of uses cognitive behavioral strategies to help clinicians support patients in behavioral changes, like in increasing physical activity. So they have a page there, the Healthy Habits, that sort of lists all of the ways that we can go about that as clinicians. And I'll pass it on to Dr. Boy.
Okay, so I have one last case, and this is a case of a 26-year-old female. She has a history of persistent depressive disorder, chronic pain, as well as obesity. Currently, she's on ODSP and living with 3 roommates and presents predominantly with mood symptoms. Last recalling feeling normal or good about 15 years ago when she was more active and doing well in school. Currently reporting low mood, energy, motivation, and lack of purpose, and also a component of sleep disturbance. For example, taking 3-hour naps during the day, falling asleep from 5 a.m. to 2 p.m. with initial insomnia due to not feeling tired. Of course, in addition to kind of psychopharm, as well as ordering a sleep study, because I think there may be a component of sleep apnea within her. We discussed other strategies, including physical activity. And this, I think, is a pretty like picturesque person who I'd say like I would definitely want to consider physical activity. And as when I was asking her what she did day to day, it was predominantly staying in her house, as she doesn't have a job, not attending school, and really spending probably the majority of her day on her couch. We know, I didn't speak about sleep specifically in the study in the adult population, but we know that physical activity is a good part of sleep hygiene. Thinking about kind of the 2 processes, so like the process S, where we're thinking like the longer we're awake, the more sleep debt we accumulate and the sleepier we become. So physical activity can definitely help with that in making us more physically tired so that we actually feel tired. And if we don't get physical activity in the day, I think it's not surprising that somebody would have initial insomnia. The other piece is the circadian rhythm piece where, she's staying inside for the most part of the day. And if a physical activity component is perhaps getting out of the house, maybe having that sunlight come in during the daytime can also help to regulate sleep. This is definitely like a picturesque population I would consider spending more time counseling on with regards to exercise. And it's also a population at a pretty high risk of having sedatives prescribed chronically, when perhaps the reason initial insomnia is present is because of how sedentary they may be during the day. So with this particular patient, I started with taking a bit of an exercise history. And she noted that she previously enjoyed swimming and felt that this was a more possible exercise with her chronic pain. So again, currently her activity is rarely leaving the house, spending most of her time on the couch, not going for walks. There's no history of purposeful exercise. It discussed with her kind of the evidence for exercise in her care. specifically saying, you mentioned the last time that you felt good in terms of your mood was when you were more physically fit. And how would you feel about integrating exercise at this point back into your life? She noted significant number of barriers, including saying, like, I would go back to swimming, but it's expensive and I would have a hard time getting there. I don't know what's safe to do with my health issues, and I have chronic pain and I don't want to make it worse. And so just highlighting these patient barriers, CDC does a good job of outlining 7 kind of concrete barriers that are present in being active, including the ones listed here. So lack of time, social influence, lack of energy, lack of willpower, fear of injury, lack of skill, and lack of resources. And I think these are very common if you start to talk to people about why activity is so difficult. They have a barriers to being active quiz. I won't read it out, but it's a 21 question quiz that patients complete so that you can figure out what their biggest barriers are. And so an example is, my day's so busy now, I just don't think I can make time to include physical activity in my regular schedule. And so there's a Likert scale associated with that, and that one would likely be associated with lack of time in terms of that barrier. So with this particular patient, I thought lack of energy, fear of injury, as well as lack of resources were predominant in terms of her barriers. And so we try to address these within some exercise counseling. And again, the CDC also outlines recommendations for each of these specific barriers and in terms of how to kind of target each one. So the fear of injury one is a big one. And really, it is kind of a skill-based one too, where, a lot of times people may have to learn throughout the process how to listen to their body, how to know when they're kind of reaching their limits, how to warm up and cool down to prevent injury, exercising appropriately, and choosing activities involving minimal risks. In terms of lack of resources, it's again selecting activities that require minimal facilities and identifying inexpensive, convenient resources available in the community. And we discussed some of that with the other 2 cases as well. The other piece, the lack of energy, the recommendations would be to schedule physical activity for times in the day where you may feel more energetic, but also, convincing yourself or knowing and telling yourself that if you give it a chance, physical activity will increase your energy level afterwards. And I think once they can at least do it once, they may be able to experience that kind of endorphin rush that kind of convinces them to continue to exercise in the future. So this is one of the resources I had provided to this particular patient in terms of targeting the fear of injury as well as the lack of resources piece. It's called Pain BC, and they actually have a whole YouTube site linked within there that's created by pain physicians, where patients who may not be used to exercise can at least have a way to integrate it, knowing that it's safe for their body, and kind of guiding patients through that. The other thing I just wanted to talk about briefly was goal setting. And I think it's really important, particularly with patients who may have a lack of energy, because there may be a big psychological component to this as well, where, of course, if you're depressed and you have low energy, you're not going to feel like getting out and going for a walk and exercising. So by actually having a goal that's created with your patient, it may be that they're able to more likely engage in exercise sessions. And so this is kind of a classic way to set a goal for exercise, where you think about frequency, intensity, time, and type. For the treatment of depression, it's often stated, you might at least target 30 minutes 3 times a week for 9 to kind of 16 weeks total. The week total is kind of not as clear. So we know that could be one ultimate goal. And for the Canada Physical Activity Guidelines for adults, you also try to target 150 minutes of moderate to high intensity physical activity. But I think the important thing is you definitely don't want to start here right away. You don't have to start here right away if your patient has limitations, or if they aren't exercising at all. It's likely pretty unrealistic. They're going to go from sitting on a couch to exercising, 150 minutes a week. So really working with them to see what they feel is realistic. So in this particular case, given that the patient was so sedentary, we started pretty slowly. We had a discussion as to what would be realistic to start doing. She decided on a frequency of 3 times a week at light intensity, which is kind of either walking or starting some of the Pain BC things at home for 20 minutes each time, and going from there. I think we touched base on this a couple of times, but just to note that these Canadian physical activity guidelines are present and free and available. They highlight not only the amount of exercise that they would recommend within each population, but also further information with each subpopulation, why it's important in each subpopulation and what they would recommend, and also specific resources for each population. And then just in terms of intensity, I just wanted to touch base briefly that most of the studies that are done for almost all psychiatric disorders are aiming for moderate to vigorous intensity exercise in the adult population anyways, and pointing out that, like, usually when I counsel a patient, I'm thinking if we're trying to target moderate to vigorous, I'd say you're probably not going to be able to talk too well while you're exercising. That's kind of the goal, being a little bit out of breath and kind of feeling your heart racing a little bit. And there's just some examples there. Just noting here that there is very good evidence for providing a written prescription for exercise. In the study, it took an average of 5 minutes for intake and counseling. With a written prescription, 73% changed their physical activity, while 63% changed their physical activity with verbal advice. So really, either is better than nothing. If you don't have the prescription, I think counseling itself can be also a very effective tool. Just going back briefly to this patient, in follow-up, she had integrated the goals that we had set. She started walking around a local neighborhood track. She said measured 800 meters 2 times per week, and also starting a 20-minute home exercise. And so you can see that's definitely not hitting the guidelines still, but it's definitely better than sitting on a couch. And I think there was noted motivation and kind of improved self-confidence when I spoke with her, that she was able to kind of do something for herself. Other effects that may improve down the line perhaps would be the sleep and further enhancement of the self-esteem and confidence. So in further follow-ups, I would typically kind of then escalate the goals and kind of continue to increase the amount that she would target. So our next goal was for her to do 1,200 meters 2 times a week, and then continuing those BC guidelines, or sorry, the BC pain course that she was doing online. And she was going to look into swimming resources as well. And then lastly, I just wanted to highlight practitioner barriers, because I think, we oftentimes point out patient barriers, but I think perhaps there are a lot of practitioner barriers as well in terms of why we don't counsel and why we don't integrate exercise into our practice. And there have been studies that looked into this, and the most frequently reported barriers would be lack of time, low self-efficacy for physical activity counseling, lack of counseling materials, lack of reimbursement, lack of knowledge and counseling skills, and patient comorbidities. And then also people who don't know who is actually responsible for counseling the patients on exercise. So they did do a study among internal medicine residents where 90% felt it was the physician's responsibility to counsel the patient on exercise, but only 15% of them actually counseled them. And then there was a study among allied health professionals, and they felt that they just did not think it was their responsibility to encourage physical activity at all. So I think, given the amount of evidence that there is for exercise specifically in our population for psychiatric disorders, I would say that perhaps we can take some of that ownership. And if it is really a 5-minute counseling session, perhaps it would be worthwhile, especially in identifying particular populations that are very sedentary and taking the time to provide some counseling. And then the other big practitioner barrier can actually be the activity level of the practitioner. So active healthcare providers, we know, are more and better, provide more counseling and better physical activity counseling, irrespective of specialty or time in practice. So maybe we need to start with assessing our own physical activity level, our own barriers to exercise, and maybe if we can experience those benefits for ourselves, and we can pass that on to our patients as well. And we're open to discussion or questions.
Thanks for the wonderful presentation. I just would like to make a comment. I checked the numbers in US. I don't know the numbers in Canada, but what US spent with Ozempic last year was 100 more than what US spent in physical activities programs. So I would like to ask you how we can translate the findings that you presented here in public policy for our patients and what we can do in terms of advocating for more programs for example, children involved with physical activities together with parents, which I think it would be great because it will have additional benefits, or even for our population, which already has, a lot of vulnerabilities, as Christina mentioned. Thank you.
Thank you so much, Dr. Bretsky, for that excellent question. I wish I had an answer. I think the challenge is that, from my perspective, with the child and adolescent population, the two main barriers are primarily cost for a lot of the folks that we see. I think a lot of the folks that we see struggle from a socioeconomic perspective at times. And so when their friends are playing hockey, which is a very cost-heavy program, for example, it's hard for them to engage with the pads and the skates and the sticks and all that stuff. Here, at least in the Kingston level, what I can identify is there's a couple of services. One is the Peterson basketball program, which is for children aged 8 to 15, I believe. It costs around $10 a year. I used to participate in that program. Don't hold that against them in terms of basketball skills, but very, very excellent program in terms of getting people physically active. The YMCA, I think I noticed that in your notes, Dr. St. Denis, and they actually have a sliding scale for individuals in terms of engaging with swimming. And in terms of parent-child programs, swimming is an excellent program. Very physically active, but at the same time, low impact. So we talked about Dr. Moy's patient who has chronic pain. Swimming is excellent for that. So I think the key is getting them over that kind of initial hurdle of the sedentary lifestyle where they're like, nothing is going to work for me. Hopefully that answers one of your questions. The second part about how we can make that part of public policy, I wish I had a better answer. I think that will be challenging because the easier answer, of course, is to, will Ozempic be that magic pill that makes me weigh less? When in fact, I think at best, that is a short-term solution at best for a long-term problem, which is maintaining physical activity. So yeah, I'll turn it over to Dr. Moy and Dr. St. Denis if they have any additional points.
Yeah, I mean, I was just going to say, I think, yeah, while not perfect, I think the States does not much in terms of prevention of anything. I think at least Canada has a little bit more in terms of our ideas around prevention of diseases. So, yeah, I don't know if there's a good answer really for that either, but, probably continue to advocate for our patients to do this stuff. And then if there's more buy-in or uptake of resources, then there might be, an awareness from a policy perspective that then we need to get more resources. I think it's probably slow. Does that kind of answer your question? Yeah. So I'll just repeat it. It was more about, and correct me if I've gotten this wrong, but like integrating sort of those community resources and with our healthcare system. I completely, I mean, I work a lot with like home and community care. And so like those multidisciplinary teams, and we try to integrate that all the time, but there are challenges for sure. Yeah. Anybody else have any comments about that at all? No? Okay. Do you want me to? Yeah. I mean, so I could tell Shabir no. So it just talks about yoga. I don't know really, and oftentimes it's not entirely clear even, and it's varied, even aerobic exercise, it's completely varied in a lot of the studies and guidelines. So John, I can talk about in the older adults, the good thing is that a lot of the studies had said no, that there's actually not very many risks associated with them. Of course, there's always the risk of injury and falls in older adults. But for the most part, the studies have consistently said that, it's worth a shot because the risks are so low.
Yeah, so for the adult population, there are actually guidelines surrounding this. I was just pulling this up when I saw the question, but it really depends if somebody has been physically active at baseline or if they have already been participating in regular physical activity. So if they've been really not physically active, then medical clearance actually would be recommended if there's any signs or symptoms of known history of cardiovascular, metabolic, or renal disease. Whereas if somebody's already participating in regular physical activity, then medical clearance would be recommended if they've been symptomatic, regardless of disease status. Then you could recommend discontinuing actually exercise at that time and seeking clearance first. Or if there's known disease and they're asymptomatic, but they want to progress to vigorous exercise intensity, then you could also recommend medical clearance. But one other thing is there's actually a safety screening questionnaire that you can provide them. It's called the PARQ, so PARQ, and that can help you to determine if you should actually be seeking physical health clearance prior to prescribing exercise. But I agree with Emily that in general, when they've done studies on kind of risks of exercise overall, there haven't been very significant risks, and generally it's quite safe to prescribe exercise. John, could you speak more to your question about psychological harms and what you're thinking of?
Do more about partner with local running clubs to create therapeutic running groups or something. And John adds, what about psychological harms specifically? Yeah, no, we couldn't hear you, John, but I've just read your question out. I think psychological harm, maybe feeling a little bit tired or something. Mm-hmm. But that's physical. Yeah. But I suppose his question is serious. He's repeated it.
And John, I don't know if this is what your question is referring to, but especially in the child and adolescent population, when you're playing competitive sports or sports and you're not particularly strong at them, it can lead to potential bullying or making yourself feel worse. We talk about how exercise can be so great for self-esteem, but if you're not especially strong at a sport and you're really struggling out there, then it can be a source of discomfort and distress. What I would say is that by and large, those cons are outweighed by the pros that you achieve from exercise. And what I often tell patients and their families is that sports is good for a lot of reasons, but it also is very strong in terms of helping you develop your social skills. So the vast majority of us are not going on to be NBA, NHL, NFL players, despite our hopes and dreams. but what you do find is that that's how you learn how to make friends, cope with difficult social situations, navigating tricky kind of dynamics with people in positions of authority. So I would strongly encourage individuals to access sports, unless there are physical health reasons like Dr. Moy and Dr. Santini described, that would prevent them from doing so.
We are nearly out of time. Just one final comment. What will be a typical exercise prescription in your specialties?
Yeah, again, I think they're very individualized. I think it really depends on what somebody's baseline is and what they've enjoyed in the past. If they like aerobic versus strength training, it very much is individualized. I think for people who are very, very, very stagnant and don't do any exercise, I oftentimes will start with walking or like stretching exercises, or finding really simple things that won't be causing them a lot of physical burden if they started all of a sudden. Because I think we've all heard of stories where people all of a sudden decide that they want to start exercising, they do a spin class, and then they come to hospital with rhabdo. So I think that's like the last thing we would want.
Yeah, exactly. And I totally agree with what Dr. Moy was saying, that it's really tailored to that individual. I know I was trying to find those guidelines, Christina, where it was like 150 minutes per 1 week period. But at the same time, it's certainly important to start slow and kind of ramp up from there. And it also depends, again, on their financial means and their interests in those types of things. So certainly kind of ramping up from a lower baseline would be my initial strategy.
Yeah, I was going to echo a little bit of what Dr. Moy, I'm working with a different population that oftentimes if I'm recommending it, it's because the person is not doing really any. So then usually I'd say like even just like 15 minutes, like something in walking in particular, just to get you moving and get the heart rate going a little bit. But I find in my older adults who are biking and running already, they're already doing a lot. Yeah.
Thanks, everyone. We are out of time now. And special thanks to people who came here in person to talk to the speakers directly. And thanks the speakers. You covered all spectrum of age group, almost all the specialties. What a great talk. Thank you very much.